You can see my cat. He's decided that today is a good day to act like a silly cat. So I'm Cora. I finished 4th year in September, and I'm integrating at the moment at the Trop School. So if anyone's ever got any questions about that, you can come and talk to me about that as well. So I'm going to talk about lower limb fractures. I'll be the first to admit that orthopedics is not my strong suite or like favorite subject, but I think it's a really useful thing, and it comes up all the time, both on like normal medical wards. There's always, or like on ortho, it's always like fractured neck of femur. So I thought we'd talk about lower limb particularly. So this is a bit of a plan for today. So we're mainly going to do hips and then describing x-rays. So why are hip fractures important? Has anyone got any ideas? You can put it in the chat. Or like, why is it a good thing to learn about? Or you can say out loud if you're feeling brave. Yeah, good. So Zara said high morbidity. Perfect. So that's one of the key things. So it's something like, I'm going to get this wrong, so don't quote me. 30% of people with a hip fracture are like dead within the year or something like that. It's quite horrific. And for lots of elderly people, it's like a very poor prognostic indicator. Vulnerable patient group, yeah, definitely. So it's about who tends to get hip fractures, which we're going to talk about in a minute. And yet, Katie's right, it's an indicator of general frailty. So it's sort of 6 of one, half dozen of the other. If you fracture your hip, you're going to have been frail because you've tripped up or whatever, but it also makes you more frail. Does that make sense? So what have I written? Common. So honestly, every hospital in the world, in the land, will have lots of fractured neck of femurs. It's also quite, they often put it in OSCEs or you'll see it on the ward. Clinically important, so if you miss it, it's pretty bad. And they're really dangerous for patients. So here we are, this is the statistics. Mortality of 10% in 1 month and 30% in a year. And because it tends to be elderly patients, it will be that fragile group who they've already like have lots of comorbidities. So you need an MDT approach, which is also a good thing to say in any OSCE, like every time. And you want to operate on them quickly as well. So in line with like the orthopedic blue book. So how do any fractures present? Really, honestly, like no wrong answers. So just tell me anything. No stupid answers. Pain, good, perfect. Anything else? So palpitations? Yeah, so you could get like some autonomic features of pain. So we had a guy in GP who we thought might have had cauda equina, and he was like proper sweating and like had a really red face and was a bit tacky. So yeah, definitely. Any others? Inflammation, perfect. Anything else? Deformity and swelling, yeah. So Hippocrates, I like a bit of like medical history. So Hippocrates described these like 5 signs that we still look for today of inflammation. So, okay, people, I don't speak Latin, but dolore is like pain, rubor is redness, tumor swelling, loss of function, calor heat. So yeah, you're effectively looking at like a hot swollen joint. How about particularly hip fractures? Oh, so Katie's already said it. So hip fractures, when they're displaced, present with external rotation and shortening of the foot. So if you see that, you've effectively got a hip fracture until proven otherwise. Does that make sense? So who breaks their hips? What kind of patients would you see in, I was at Southport last year, so what kind of patients would I have seen on the ortho ward? Yeah, elderly, women. Good. Why women? Why particularly women? What risk factor? Yeah, so they're more likely to have osteoporosis. And why is that? Yeah, because of the menopause. Perfect. So the lack of estrogen. Anyone else who's more likely to break their hip? So let me see what I've written. Okay, so young people who break their hip, they tend to have been in like, they've had a horrible car accident or they've been proper knocked off their bike or something like that. So if I fell over, I, touch wood, wouldn't break my hip, or one of you wouldn't break your hip. But if you've already got this like osteopenia or osteoporosis, then you can do it just from like tripping over. This is what a hip fracture is. This is what I'm talking about. So you can get these pelvic fractures as well, which are what you talk about in like the polytrauma. So these are the people who've like been crushed on their motorbike or whatever. So they're the patients who get helicoptered off to Aintree and you just put them in a pelvic binder. So I'm not talking about them because they're an entirely different management and topic and like that. So yeah, this is what the definition of a hip fracture is. Someone already said it's like older patients. So some medications. So why do steroids increase your risk of a hip fracture? It's like a similar reason. Anyone? What's like a common side effect of steroids? This is always a good OSCE question. Because they increase your risk of osteoporosis. Yeah, good. And as like a side topic, anyone know other side effects of steroids? I've been asked this by so many people, so it's a good thing to like go over. So you can start from like the head down. So what face do they typically have? It's like a horrible word to describe it, but so hyperglycemia, yeah, moon face. They talk about like buffalo hump, central obesity, abdominal striae, skin thinning, anything like that. And bisphosphonates, so we use them to treat osteoporosis. Yeah, good, proximal wasting. So what's it they talk about? Something like lollipop on a stick or something like that. It's a really weird phrase. I can't remember what it is. But yeah, bisphosphonates, so like alendronic acid that you prescribe for osteoporosis, there's some evidence that they cause atypical femoral fractures. They cause like lower femoral fractures. But there's a bit of controversy about whether that is like a cause or a correlation. But yeah, that's always in past medicine. And this is a really important one as well. So people, some people do just like trip over their rug or whatever, but you need to make sure that they didn't have an MI or have like a cardiac syncope and then fall, or have a stroke and then fall. Does that make sense? So how do hip fractures present? So someone has already said classically shortened, externally rotated leg. Why is it shorter? This is a good question for like ward round. People always ask. And why is it externally rotated? It's the same reason. Anyone know? Yeah, the femur moves back and up. You're right, Katie. Why? Do you remember? It's a certain muscle. And rotates upwards due to gluteus. Yeah, and the psoas as well. So you can see where like the attachment is, and it just pulls up. Does that make sense? So that's why you get, but it only happens if the fracture is displaced. So if you have a high clinical suspicion of a hip fracture, but the leg looks normal, that doesn't really mean anything. Does that make sense? So if it's there, it has like a high positive predictive value, I think would be the right way to say it. But if it's not there, it doesn't mean that it hasn't happened. So how do you manage a neck of femur? So Mrs. Jones is 83 and has come in. She's got quite a lot of pain. She's uncomfortable. She's a bit confused. Her son found her on the floor after not hearing from her in the morning. So how are you going to manage Mrs. Jones? Anyone? You can say this for any initial management of any like trauma. A to E, good, Katie. So honestly, like this has saved my life so many times. If you don't know what to say, like I start with an A to E assessment. Such a good thing to say. And it gives you so much to talk about because you know it already. Good. So if your A to E assessment is normal, these people are at risk of a lot of like secondary traumas, because if you think you fell over and you broke your hip, you quite easily could have like fractured your wrist as well at the same time. Cat, sorry, 2 seconds. Stop it. Sorry, he's like being very badly behaved. Yeah, and then you're going to give us some analgesia. So What's like bottom on the analgesic ladder? Does anyone know? But like, what's a common thing? Yeah, good. So paracetamol first of all. So you could give IV paracetamol. So we had a question about this in our mock final. You would give IV paracetamol, and it's good synergistic painkiller. But what medication would you also probably give her? She has broken her hip, probably. So are you just going to be mean and give her paracetamol, or are you going to give her something a bit nicer? Codeine. So you're right. That would be like moving up the analgesic ladder. But because it's acute pain, you can give morphine. Does that make sense? Because codeine probably isn't going to cut it, and it might make her constipated, and it might just give her a bit of delirium, whereas realistically she's going to need morphine. Does that make sense? And you can also give this fascia iliaca block, which NICE says everyone should be offered. I've never seen it, but apparently it's like a thing. So why is it not good to give old people lots of morphine, or anyone lots of morphine, really? Yeah, good. Drowsiness. Anything else? Respiratory depression. Perfect. Anything else? If you're already a bit muddled, constipation, yeah. Addiction, yeah, definitely. And yeah, it worsens delirium. So she's already a little bit confused because she's been on the floor for a little while. She's probably a bit dehydrated. If her renal function isn't great, then it's not necessarily the best thing to give long term, but in the short term, we can definitely give this. Does that make sense? But the fascia iliaca block is supposed to be offered to everyone. I've never seen it, but maybe that's because I haven't been in the right places. I don't know. And you need to work out why they fell. So if they've got AF and they've thrown off a clot or something, that's really important that you detect that. So how could you work out why they fell? So all you know is that her son found her, and she doesn't know how long she's been on the floor, and she's a bit muddled. So what are you going to do? OBS, yeah, heart rate for arrhythmia, BP, ECG. Anything else you do even before your OBS? Good. So history. So you can try and get a bit of a history. You can try and get a history of her son. So she's a known cardiac patient, for example. You might be a bit more worried. And you've already done your like quick A2E examination. But yeah, OBS, heart rate, ECG. If she's got a new murmur, so you do a bit of a cardiorespiratory exam. Why else might an older person be confused? What's a cheap, easy bedside test that you can do? Even you can do it as like a medical student. Yeah, good. So you dip a urine. So the presence of, I didn't know this, I found this out like fairly recently. So you wouldn't just treat an asymptomatic bacteria, but if she had confusion, then you're all right to treat her. Because so a lot of people over 65 just have like a little bit of bacteria or white cells in their urine. But if they didn't have any symptoms, then you wouldn't treat it because it's not necessarily an infection. But if they have symptoms, then you can treat them. Does that make sense? Yeah? Everyone happy? Stop me if you're not happy, okay? So, diagnosis. So how are you going to diagnose this? Honestly, it's not a trick question. So she's got a short and externally rotated leg. You've done your A2E assessment. Yeah. What kind of x-ray? So Katie's put x-ray hip. You're right. And then Zara's put scan. So what scan do you mean, Zara? So you're right with the x-ray hip, but if the x-ray hip didn't show anything, what kind of scan would you do? So you're doing AP and lateral x-ray. Yeah, good. Why are you doing an MRI and not CT? And then you can also do this other view, but I've not really seen it very often. Just said it on Radiopedia, so I thought I should tell you. Yeah, so more clear with the bones. And also, I guess, it tells you the degree of soft tissue injury. In practice, trying to get an MRI at 3 o'clock in the morning probably isn't helpful. So you can do a CT, but MRI is like gold standard. Does that make sense? So in your OSCE, you'd say, I do AP and lateral x-rays. If they didn't show anything, but I had high clinical suspicion, then I do, and then I know MRI is gold standard, but if I couldn't get an MRI, I might do a CT. Does that make sense? But as an F1, I don't think you'd be expected to be like, well, yeah, I'm going to do the CT. So yeah, if you don't see anything but you're still worried, you can do an MRI or you can do a CT. And you're going to refer them to ortho or orthogeries. So orthogeries is like a new speciality, or newish, I think. I'm not sure. But they effectively deal with these like patients with lots of comorbidities. So what types of hip fracture are there? So I've already written some of it on there. So intracapsular or extracapsular. So where, like, what does that mean? What's the difference between the two? Or if you don't know that, you can tell me displaced or undisplaced. So that literally does what it says on the tin. So above the trochanterus, yeah. So you can see where that little dotted line is. So that is like up from that, so towards the neck and the head is intracapsular. Down from that is extracapsular. Good. And that's how you can do that for like any joint. So if it's within the joint, it's intracapsular. And if it's outside the joint, it's extracapsular. And then displaced or undisplaced. So what do those words mean? Anyone? Yeah, good. Basically, yeah. Whether things have moved or whether things are in the right place. So I don't think you need to know this. It's a good thing to remember. I wouldn't be bothered about learning like the different stages. Whenever I'm learning like a staging system, I basically just learn what like one is and what the worst one is. And then you can pretty much work out the ones in between. So Gardner's classification, I remember it because like a lot of older people do lots of gardening, and they also tend to break their hips. So that's a quite good way of remembering it. So these are the classifications of hip fractures. So you can see that stage 1 is just an incomplete fracture, where it's like tilted a little bit. That's still undisplaced, stage 2. Stage 3, there's some continuity. That's not a great one, to be honest. It's not showing it very well. There's some continuity, but it will have like slipped a little bit. And stage 4, literally the socket and the femur are completely disrupted. So out of all of those, which one is going to make you think, oh no, that's not very good? And which one will you be like, oh, I'm less worried about it? Yeah, 4's bad, pretty much, yeah. So if it looks bad, then it probably is bad. So it's like when you see like comminutive fractures, so fractures that are all just different parts, obviously that's much worse, and you're going to need much more surgery or orthopedic input than if it's just an underspaced fracture. So why do we worry about that with hips, particularly hips? Yeah, I agree with Katie. So why hips more of a concern? Well, not more of a concern, a concern. So it's something to do with the blood supply. Avascular necrosis, perfect. So I had to look this up because I didn't remember it. So in first year, we learned the blood supply of the hip. Does anyone remember what it was? Or maybe people in the younger years will be a bit better at this. I had to look it up. I remembered 1 out of the 3. Oh, okay, yeah. I mean, Katie knows the stuff. Yeah. So the profunda femoris. So you've got this big one, basically, which is like the most important one. Yeah. So this is the lateral medial circumflex. So I think this comes from the profunda femoris, and you've got these branches which go round. So you can see that if you disrupt the joint, then it's going to cause problems for the blood supply at the top of the hip. So let me see what I got. So this is the retinacular, which is the main one, which I think comes from the profunda femoris, and then consists of the lateral and medial circumflex. And then the other ones are the foveal, which is number 3, and the metaphyseal, which is number 2. I don't know. I think it's important to remember that fractures of the hip can cause avascular necrosis, maybe it'd be really good to remember the 3 main blood supplies. If you want to be an orthopedic surgeon, go away, learn all the blood supply of the hip. If you don't, I reckon knowing that it causes avascular necrosis, that it can be disrupted by a hip fracture, are the most important things. So how would avascular necrosis present? Anyone think? It's literally like, yeah, quite simple. Yeah, literally like hip pain. So someone who's had a fracture and it hasn't quite healed, something like that. Claudication, I don't know, maybe. The main things I can think of are like hip pain, loss of function, and you can also get infection, because if you think about it, if you have like a rubbish blood supply, and people wouldn't be able to walk. But I mean, maybe claudication's right, I'm not sure. This is like an extra bonus point. What other bones are at risk of avascular necrosis? Scaphoid, yeah, good one. Any others? I think the others are like the talus and I looked up another one. Those are the 3 main ones, I think: the hip, the scaphoid, and the talus. But there is another one which I can't remember right now. I'll come back to it. So, and this is from Pulse Notes. So this is how you manage hip fractures. It looks really scary, and it took me ages to understand it, but it's actually not that bad. So effectively, you divide them into intracapsular and extracapsular. And then intracapsular displace, that'd be like, do you remember we saw stages like 1, 2, 3, 4? That'd probably be like 1 and 2. So if they're under 70 and they're well, you can do internal fixation. So why would you choose that over a total hip replacement if you're under 70 and well? So what happens to hip replacements? Do they last forever? Why would you choose a hemi? We'll come on to that in a sec. Hip replacements don't last too long. Yeah. So effectively, if you do a hip replacement and someone is, I don't know, 55, then they're going to need another one when they're, I don't know what their lifespan is, but like 70, let's say. Or if you do it when someone's 35, they're going to need at least 2 new hips. Oh no, sorry. I'll come on to that in 2 seconds. So the comorbidities. So yeah, why would you do, so in terms of hip arthroplasty, you can do a total hip replacement. So you get the like pubic, what's it called? You get like a cap over the acetabulum, and then you have 2 metal bits effectively. Or you can just do a hemi where you just replace the ball. So a total is like the ball and the socket, and the hemi is just the ball. Does that make sense? Some orthopedic people will be like killing me right now, but I feel like that's all you have to know, really. So if they're over 70 and they're well, you can do a total hip replacement, because that will last them probably the rest of their life. If they got comorbidities, why do you do a hemi? Why don't you just go for it and do a total hip replacement? And they'll probably be fine. So yeah, I guess you could do a full in the future. Yeah, so it's a longer procedure and it's more invasive. So if you've got someone who you need to fix the hip realistically, but you're a bit, the anaesthetist is a bit not sure about putting them under loads and loads of anaesthetic or giving them a spinal, then you can do a hemi. Does that make sense? But that will mean that you're not going to get the degree of function that you would have if you had a total hip replacement. Is everyone happy with displaced? So effectively, you have to put it back together. Hip arthroplasty is just like changing the joint. It's like a hip replacement. Does that make sense? I feel like if it doesn't make sense, shout me. Okay, sound. So undisplaced, if they've got no comorbidities, you do internal fixation. So that's just putting it back together. And if they got comorbidities, you do a Hemi. Takes a little while to get your head round, but is everyone vaguely following? It's something I had to go over like a couple of times before I did my finals, I'm not gonna lie. But the key thing to remember is basically comorbidities, Hemi, and then you can do variations on like internal fixation. So, oh, did I not put extracapsular? Oh, okay, I messed that out. So extracapsular, I will talk you through it. So effectively, there are 2 operations you can do for extracapsular. I don't think you need to know the details of them. So you can do an intermedullary device, which does what it says on the tin, where basically you have the shaft of the boat and you like hammer. If you've ever seen it, it's pretty brutal. They hammer like a big nail down the middle, and it holds the bone together. Because you remember this is past the truncat, past the joint capsule. So you're effectively just trying to keep the femur together. Or you can do something called a dynamic hip screw, which is pretty similar, but you drill into the hip as opposed to like straight down. I'll try and find some photos at the end if we have time, but I forgot to put that on, sorry. If you just have any questions about that, then let me know. So how do you manage these patients post-op? Because if you go to the wards, I've seen maybe like 2 or 3 pre-op, and you mainly see them post-op. MDT approach, perfect. That's for like everything. So what members of the MDT, yeah, perfect, you've already answered my question. So physio, anyone else you would involve in this patient's care? So what was her name? Mrs. I can't remember. OT, yeah. Good. Anything else? Anyone else? If she lived in a home by herself and you were worried that she wouldn't be able to cope when she went home, who might you call and be like, can I have some help? Yeah, like social worker or social services. Yeah, good. Yeah, so the social services would then go on to support, like get some care services in. Perfect. What were we going to say? Oh, so you need to do DVT prophylaxis on these people. So you try and get them up and moving the next day. But obviously, even if you're a normal patient in hospital, you're still in bed quite a lot of the time. So you need to do DVT prophylaxis. And I cannot for the life of me remember whether it's 6 months or 3 months, or if it's until they regain their mobility. I'd just say trust guidelines. I'd be like, I follow trust guidelines on DVT prophylaxis. But yeah, you just need to bear in mind that they're at high risk of that. A lot of these patients get delirious. So I was at Whiston in 3rd year, and there's an Ortho Jerry's ward where there's a lot of patients who are at risk of delirium. So what are risk factors for delirium? So I don't think you do DVT prophylaxis pre-op because you operate on them really quickly. So you're supposed to operate within 36 hours of presentation. I think it's even better to do 24 hours. And obviously if you did DVT prophylaxis, then you'd increase their bleeding risk. But I think it's 6 to 12 hours after they've had their operation, you have to start DVT prophylaxis. Unless obviously they've got AF or another, I don't know, von Willebrand's or something like that. Or like active protein C deficiency, stuff like that. So who gets delirium? It's kind of the same group of people. Yeah, good. I didn't know constipation could cause delirium, but apparently it's super common. So if you imagine you're giving them lots of opiates, they're probably going to be pretty constipated. And also, if they're in a room with like, how can we prevent delirium? What are some like good strategies? So good lighting, that's like a really important one. Yeah, so good lighting, so making sure that at night the lights are off, so it's nighttime. Yeah, good, not putting people in a side room. So that's a tendency if someone's like shouting a lot, they'll be put in a side room, but actually it's better to have them coordinate, like talking to people. What are other strategies? Treat constipation, stuff like that. Put a clock up with the date. Yeah, all those sort of things. Keep people really well hydrated. Try and get them, make sure they're drinking and eating properly. What else have I written? Okay, so I didn't know this, but it's a good thing to say. So you can get like, infections aren't that common because you know how strict orthopedics are with like, don't go in the blue square or whatever it is. They're like, what's called negative pressure chamber. They get a bit funny with you. But if you do get a post-op fever, what could be the causes? And there's 7 W's, which aren't really W's, but it's a good way to remember it. So, or you can just tell me some causes of a post-op fever. Anyone? Infection, good. Where? Where could you get infection? Wind, rasp, yeah, go on, Reese. Water, yeah, so you can get a UTI at the site, perfect. Walking, yeah, or like veins, yeah, so definitely from catheters. So I will. So when, this is like in order of when they present. So wind is in a respiratory infection. These are a bit dodgy, but they help me remember it. It's like 1 to 2 days. Water, I think it's like 3 to 4 days or 2 to 3 days or something. Wound infections are like day 3 post-op. Walking or like not walking, so like DVT. Some drugs can cause fevers, and then you can get like a phlebitis, like an infection of the veins from having like recurrent cannulas, and also an abscess, which is called wabscess, to help you remember it. Does that make sense? Yeah. So when do you take an x-ray? It sounds like we're going back, but we're not. There is a like method in the madness. So if you're worried about a fracture, yeah, good. So if you're worried about a fracture, but if we x-rayed everyone with a swollen joint, we'd be, or who came in and was like, I'm worried I've broken my leg, then we'd be x-raying everyone all the time, which obviously is not great. So there's some rules with high sensitivity. So particularly for ankle fractures, does anyone know the name of a rule that you can use which tells you you need to x-ray them or you don't need to x-ray them? It's related to Canada. And it's named after like the hospital it was developed in, I think. Yeah, go on, something. Anyone else can guess from that? Ottawa, perfect. So you did right. I don't think you need to know these. I was with the GP and she looked them up, so I feel like it's fine. So I only knew the ones for ankles. I didn't even know them, but I knew it was a thing for ankles. So you can, if you have pain in the midfoot and any of these, I think it's sensitivity. So that is, from my understanding, how likely it is to miss something. So basically it doesn't miss ankle fractures. It's like 99% or 98%. It's specificity, so how often you x-ray and you see ankle fractures is only 30 to 40%, but they reckon it cuts down unnecessary x-rays by about 40%. So it's good to have these rules, and also it's something to hang your hat on. So you know, I've done the right thing by not x-raying this person because it's not in the Ottawa ankle rules. Does that make sense? I didn't know that it was even ones for the knee. So you only do it in children from 3 and adults up to the age of 55. But I think just knowing that there are certain criteria. What's Ottawa? It's like a set of criteria where you should where you should x-ray an ankle. So if someone comes in and is like to your GP surgery and says, I'm worried I broke my ankle, you examine them, and then if they got pain in the midfoot zone and any of these ones, so at the very top, so bone tenderness at the navicular or at the 5th metatarsal, or inability to weight bear immediately and in the emergency department, then you can x-ray them. But if someone comes in and says, I was at hockey and I sprained my ankle and it is a bit sore, but I walked to the GP surgery, I walked home, walked to the GP surgery, I'm a bit sore on the top of my shin, then you don't need to scan them. Does that x-ray them? Make sense? If it doesn't, shout me. Yeah, perfect. So what can you look for on an X-ray that might suggest a fracture? Literally, like anything. Tell me anything that makes you think that looks dodgy. Breaking the periosteum, perfect. So what I do, because I'm not very good at just like looking at it, so I have to get a pen out and like trace around it, and that enables you to see breaks or like irregularities where you wouldn't necessarily see them. Yeah, good. I'm glad I'm not the only one. Anything else? What have I written? So disruptions like the cortex or the periosteum. Yeah, perfect. Anything else? What if the bone had a onion skin appearance? Obvious lucent lines, good. So you're like high or low opacification, which is the posh words that you can use. I'll go through the others. Soft tissue swelling. That doesn't tell you huge amounts, but if there's huge amounts of soft tissue swelling, then you know that there's been some obvious like trauma. And if you see a bone and you think that doesn't look right, then that could be malignant. So if someone comes in and they've got like hip pain, but it wasn't obviously, they didn't fall over and get the hip pain, they just happened to stand up and get the hip pain, then you should think that I'd be worried about that patient. Does that make sense? I'll carry on. If it doesn't, shout me. So describing a fracture. So this is one of my least favorite OSCE stations. I think we got it in second year. And we got like an avulsion fracture of the ankle or something like that. I can't remember. And it was horrific. So ever since then, I've learned how to describe a fracture. Third year. Oh, was it third year? Sound. So we talk about, so you can talk about the patient, and obviously a good thing to say is like, I want to correlate this clinically. So sometimes you can see, Alex hated that station too. Good, I'm pleased everyone hated it. So sometimes you can see an X-ray which you're not really sure of, but if the patient hasn't got pain, then it's very unlikely to be a fracture. And then you can describe what type of fracture. And also, just to go back to the patient thing, if you're talking about like, this is Mr. Smith, he is, it gives you a minute to like look at the fracture and think about it if you're in like an OSCE situation or on a ward round or something. So you can describe the type of fracture, the site, the degree of displacement or not, and anything else that looks dodgy. I don't have like a good acronym. Does anyone else have a good acronym that they like to describe fractures? I feel like I've got a good one for ECGs, but not fractures, but it all sort of makes sense though. And also it's not like, you know, like an ECG, it wouldn't make sense to be like, oh, there's ST elevation in lines 2, 3, and 4, and also there's AF, and also there's so A, B, C, D, yeah. A, B. Go on.
It's I heard it from Orthopaedics, and as well as describing everything about the fracture, just to like be complete, you do alignment, so any dislocations, you do the bone, so like osteopenia or any like other bone growth, the cortex, so you follow around the cortex and the lines, and then S, soft tissue, and look for like any inflammation. So
that sounds really good. So yeah. That's a good one.
Yeah.
So I think we'll cover all of those, but not in order, but that's a really good one. So A, B, C, S. Perfect. So I've got a couple of hip fractures. Oh, I've given the game away. Okay, I've got a couple of hips that you can look at and tell me about. So I thought we'd go through the first one together, and then if someone is feeling brave, they can describe the second one. So don't immediately look for the fracture, which is what the temptation is always to do. So let's say you talk about the patient identifiers and you'd be like, oh, this is an AP X-ray, blah, blah, blah. And then these are the types of fractures you can get. They basically do what they say on the tin. So transverse, it should like goes all the way across. Oblique is at an angle. Oh, you can all read. I'm not going to read them to you. Comminuted is like bad, basically. It's all in like lots of little bits. Does anyone have any questions about these? Green sticks are really common in kids, as the torus, because their bones are like soft. And a lot of like these ones you can manage conservatively, I think, most of the time. So what type? So can anyone see any abnormalities, or does anyone want to take me through this X-ray? What side is the break on? Because I've already given away this break. The left. Perfect. Good. So is there anything else you can tell me about this patient? Probably not. Or as soon as there's anything else interesting on the X-ray, but there's not. Yeah, good. And is it intracapsular or extracapsular? Yeah, good. It's an intracapsular fracture. What else do we need to talk about? So you can talk about the site. So you can always talk about it anatomically, which is what we're doing when we're like intercapsular or extracapsular, or you can talk about it where it is in the bone. Either is fine. So we've already done that. And then we can talk about the degree of displacement. So translations where like the bone's moved, angulations where it's bent, rotation does what it says on the tin, and impactions where it's been like pushed together. So what do you think might have happened to this bone out of those 4 options? I'll tell you one of them has happened. So can you see my mouse? Or not?
Yeah,
you can. Sound. So if anyone can't see the fracture, don't worry, I'm not very good at spotting fractures. So you can see it just here. So it's increase like opacification. If you weren't sure, you can always compare the 2 sides, which is good. That's why it's nice the human body is vaguely symmetrical. Or you can go around with your pen and then be like, so here you can see there's some disruption. So this is increased opacification. So what does that mean? So the bone is moved. Yeah, good. So effectively, if you have 2 layers of bone, it's going to be much brighter. So you can see where the spine is. If we look up here, you've got much brighter, like it's much whiter there. Does that make sense? So is the bone normal, or are there any other fractures? That's like a trick. So there's, I don't think we had it in our year, but maybe a few years ago, they showed a chest X-ray, and it was a normal chest X-ray. There's like a fractured neck of femur. No, not fractured neck of humerus. But people didn't pick up on it because you're thinking, oh, I'm looking at a chest X-ray. The chest X-ray is normal, or it had like pneumonia or something. So it's really important to look at the other bones in the frame. And also, if you've broken one bone, then you might have broken another, especially in like polytrauma. In terms of the bone looking normal, what would make a bone look abnormal? So we go back to here. Obviously, there's a fracture, but the rest of these bones to me are pretty normal. So what would I be looking for that make it look a bit funny? Metastatic lesions, good. What do they look like? Yeah, so you can get like bony overgrowth, or you can get like disruption of the bone. Does that make sense? I'll show you one in the end. And then like primary bone tumors, they can all look a bit strange. Or you can see like Paget's disease, but that's super rare. Okay, so does anyone want to be brave? Oh, I've looked at that one. So how would you manage this patient? I've sort of given you the answer. So it's intracapsular. And let's say she is 82 and she's not in great health. She may just potters about her flat. So how would you manage her? Hemi, good. Makes sense? And there's likely damage to the acetabulate head. You obviously wouldn't be making this decision as an F1, so it's not something I want anyone to worry about. It's just a good thing to know like what their management would be. So that's the little thing again. So this is obviously quite bad. Does anyone want to describe this X-ray to me? Or you can just put some comments in the chat if that would be better. Good. So subtrochanteric displace. What kind of fracture is this? So I think that's in 3 bits there. So what would we call that? Looks atypical. Yeah, it could be like a traumatic one. Yeah, definitely. Yeah, So I would, that's either a spiral fracture or that is a comminuted fracture. And it could be, I think you would call it comminuted, but yeah, I can see why you think it's a spiral fracture, because I thought that at first as well. But I think, can you see here? It looks like there's also some disruption of this part. Yeah? So you've got one part of the leg here, one part of the femur here, and then you've got this extra bit here. Good. Is the left side okay? Hadn't thought of that. No, the left side also looks dodgy. See, this is why we should look at the whole X-ray. I don't think that left side looks very good either, but I was mainly focusing on the right. Let me think. You know, so here you can see that there's this angle should be like nice and soft. So it'd be like should be a gentle U shape, and you can see that this side is also broken. So this person's got bilateral hip fractures. So how might this happen? How might you get bilateral fractures? Yeah, so like an RTA or like any major trauma. Perfect. Oh, and so how would you manage this patient? It's not a trick question. Yeah. What did you do before that? Yeah, A2 assessment. Perfect. Yeah, you can say that literally about anything, and they'll be like, "Oh yeah, that's a really good idea." Yeah, and you would definitely give this person some painkillers. You might even give them some like ketamine or something, because this is pretty horrific. So this is not a great film. Sorry, guys. What's going on here? I think this is the last one. So if we look at this angle, is this a nice, smooth? Should your hip look like this? Would you be happy if your hip looked like this? Intercapsular fracture, good. Is it displaced or undisplaced? Displaced, good. So this part, this greater trochanter shouldn't be up here, should be down here. Does that make sense? And how would you manage this person? So it's an intracapsular fracture, but they are 42 and cycle to work every day and normally fairly functional. Total hip replacement. Yeah, what would you do? You could do something else first. So it's displaced. So do you remember we said if they were younger, you'd be a bit more worried about doing a total hip replacement? Yeah. So you could do internal fixation. So dynamic hip screw. So the big long screws that go through the nail, go through the bone, are for the extracapsular fractures. You can do internal fixation, so you effectively squeeze it all together for something like this. If that didn't work, or I don't know if I could do it because I'm not an orthopod, but you might consider total hip replacement. Does that make sense? Yeah. So dynamic hip screw, intermedullary device, extracapsular, and then internal fixation for intercapsular. Yeah. So dynamic hip screw is extracapsular. I'll try and find some pictures if you guys want. Is that all right? Sorry, I didn't have the little diagram for it. Perfect. Has anyone got any questions or anything they want to go through, or do you want me to show you what a dynamic hip screw is? Okay, so I thought this question would come up. So it depends on the type of fracture it is. So if it is, you don't have to know this, but it's an interesting thing to know. So if it is a reverse, oblique, transverse, or subtrochanteric fracture, then you do an intramedullary device. If it's any of the others, you do a dynamic hip screw. Surgeons, so there's a lot of debate about which method is best. I think some surgeons like one method, some surgeons like the other method. and it depends on the patient in front of them. But yeah, so if it's a non-special type, it's dynamic hip screw. If it's any of the other special types that I mentioned, so reverse, oblique, transverse, subtrochanteric, you need an intramedullary device. Does that make sense? Yeah. Anyone got any other questions? Okay.